Okay, ladies and gentlemen, welcome to this latest teaching session in the class on technology and the future of medicine. Today we're talking about the singularity and the have-nots, the provision of medical care in resource-limited settings, and with a specific example of Nepal. I just have a few remarks. My remarks probably vary in how memorable they are to you. Maybe what I'm about to say will be more memorable than usual. I'd like each of you to find your own replacement for fall 2013. The rationale for that is I kind of like you guys. You seem like an ideal group of 14 to 18 people. And it's a lot of work for us to promote this course the way we've always promoted it before. And the direct personal contact from you to the people that you know, if you do that early enough, it will become apparent to me that we don't have to do that, and that I don't have to promote the course, that enough students will sign up for it naturally without that. If you don't do it, it will become apparent to me that we don't have enough students signing up, and we'll mount the effort of doing campus-wide posters and all the things that we've always done before, but that will just get us generic students of unknown quality, right? Whereas if you guys bring replacements for yourselves, we'll get really high quality students. That, yes? I think it's up to you. We can deal with all kinds of personalities and yeah, there's no set mold. You guys are extremely heterogeneous, as you realize, and that's fine. So I'm not looking for any particular kind of student, but I thought it'd be fun to make this kind of self-organizing in this way where you guys go out and talk to your friends about the course rather than us just trying to promote it to the whole campus as we've done previously. So that's one surprise. I have two other surprises for you about the course, things you may not have known. And the next one has to do with the relationship between myself and Earl Waugh. So for about 10 years, Earl and I both had offices on the 9th floor of College Plaza Professional Building. We'd see each other in the hall, but I didn't know who he was, he didn't know who I was. We actually met in January 2011 on a TV program where this TV producer thought it'd be really cool to get the two of us talking about the future of the Alberta healthcare system. And I realized this guy looked awfully familiar. And so that's how we actually met, on a TV set. And of course, the background there is all faked. You know that the usual way to do that is with a green screen, right? So we're just sitting in front of this homogeneous green screen, and then later on they put in, the buildings and all the fancy stuff. So what you see there, we didn't actually see. So that's about me and Earl Waugh. And then the story of me and Bibiana is similarly curious. We work in the same hospital, and we worked there for many years. We even work on the same floors of the same hospital. But as far as I know, we'd never seen each other, we'd never met before we both went to the October 2010 annual consultative meeting in Nepal. And I had heard about her, and she'd heard about me, and we actually met there. So that, we tried to figure out why we had never met previously, but anyway, it doesn't matter. And what's the importance of Earl Waugh and Bibiana Cujec in this course? Well, the whole course is dependent upon them in the following way, that we decided this should be a balanced course with diversity. So we needed not only tech enthusiasts, but tech skeptics. And I thought that she and Earl Waugh fit in that tech skeptic category. Of course, nobody is rigidly any simplistic category. Human beings are, each unique and so on. And so, as you know, Earl Wah has a lot of interest in technology. I don't know if he always did, but he certainly does now. And similarly, Bibiana does too. But in the beginning, the idea was they were more skeptical about the sorts of things that we talk about in this course than most people are, and those were points of view that we needed and valued. So that is the original idea, and I think the presence of both of them in this course has turned out exceptionally well. So the father of cellular pathology, Rudolf Virchow, you've heard this from me before, but I think it applies particularly to the situation in Nepal, and he wrote this in 1848 when he was 27 years of age. It is the curse of humanity that it learns to tolerate even the most horrible situations by habituation. Physicians are the natural attorneys of the poor, and the social problems should largely be solved by them. And if you think of the problems of medical care in Nepal, there are big areas of the country that have never seen a physician, that have never seen a nurse, that have no health centers, and so on. So it's really something beyond just the quality of care. There are places where there is no care, where you have to travel a long way to get care. So it's a whole different level of challenge. And it gets beyond the questions about the care of the individual ill patient to problems of society. And this is a country that's recently ended a long civil war, and the medical care there has been an important part of the healing process. So we're talking then about medicine as a field much larger than we've ever considered before, including not only disease, but human enhancement, physical and moral, and improvements in society. And if that's true, then medicine has a responsibility to be more than just the kind of self-interested financial silo competing with all of the other self-interested financial silos, and to be something with more of an overall humanitarian focus if it's involved in some way in all human endeavors. So this presentation on Nepal and the Tuesday's presentation on obesity both emphasize this social responsibility of medicine. And it's kind of cool that with this theme of medicine writ large, there's actually a paper about Nepal that has that phrase in the title. It's called Practicing Politics as Medicine Writ Large in Nepal, and it's about the role that physicians have played in the healing process after the recent Civil War. So anyway, that's what I had to tell you about today, and I hope what I said in the beginning about finding your own replacement, I hope that you're enthusiastic about doing that. And so now I'm going to change to Bibiana's PowerPoint.
Well, good afternoon. It's great to see so many people here. I think this is about the third or fourth time that we go through this iteration of the course, and I'm sure it gets better every time. So I'm Bibiana Cujec. I'm a cardiologist, and I practice at the University Hospital, the Alberta Heart Institute. And like Dr. Solez was saying, I met him for the first time in 2010, and that was my first trip to Nepal as well. How many of you have been to a developing country? So about 4 of you, yeah. Well, it took me a long time to get to a developing country. I mean, in 2010, I was about 50 years old, and that was really my first trip to a developing country. It was such a big shock to me. So it made a profound impression on me, and I'm going to tell you about healthcare as I observed it, and life as I observed it during my 3 visits to Nepal. I'm just going to get out of, I've got a, I don't know, the display here is kind of on and off. So first of all, a few words about Nepal. So Nepal is a country of 3 million people. And as you can see, China is to the north and India is to the south. So it's kind of squeezed between 2 giants. The main religion is Hindu, but about 20%, 15-20% are Buddhists. And what was really remarkable in Kathmandu was kind of the mutual respect people had for other religions and how they would go by the shrines and make offerings, even if it wasn't their primary religion. The language is Nepali, but there are many different ethnic groups in Nepal. 80% of the population is rural, so Nepal is really divided into 3 different geographic zones. The north is the mountains, the Himalayas, and many of the world's peaks that are over 8,000 meters are in that region, including Everest, of course. And then the hills is where Kathmandu is. Kathmandu is in a valley in the hills, and the southern part is the Terai, which is like plains, a lot like northern India. So when we compare Nepal and Canada, there's some similarities. The population is similar, but of course the area is so much greater for Canada than in Nepal. The literacy rate is very low in Nepal. It's about 60% of people over the age of 18 years old are able to read. So it's very low. In Canada, it's 99%. The life expectancy at birth for males and females is one of the lowest of all the countries. There's about 198 countries, and Nepal is ranked 168th in terms of life expectancy. So very, very low. 65 years for men and 69 years for women. And you have Canada's numbers in comparison, and Canada is ranked about 8th among the countries of the world. Infant mortality is very high in Nepal, although it is improving. There's a big discrepancy between rural and urban populations. On average, the infant mortality is 55 children die out of 1,000 that are born. And that can be as high as 1 child out of 10 dying in rural settings. So about 100 out of 1,000. So very high. So very poor country. And yet, Nepal has had a lot of foreign aid, and there's a lot of tourists go to Nepal because of the mountains. The Himalayas attract people from all over the world, and they're truly magnificent. They dwarf our Rockies, or the Andes are pretty high as well, but certainly the Alps. You know, these are peaks that are over 6,000 meters, up to 8,800 meters with Everest. So beautiful mountains. And I love the mountains, I always have. So my first trip to Nepal was a combined trek, as well as I had received an invitation to be part of a new medical school that was being built in Kathmandu. So it's kind of like 2 things that converged, and they were both important to me. So that's how I came to be in Nepal in October 2010 for the first time. And one of the things you learn in a developing country, you know, here we always feel we can control things, and you know, we're very busy with all our devices, and yeah, things usually work on time, more or less. Well, in Nepal, it's a different world. And that's the first thing you learn. On the flight to Lukla from Kathmandu, Lukla is a small village, and that's where like the treks to base camp of Mount Everest go through that Khumbu Valley, and Lukla is where you fly to. And this little village has that small little runway, and the little planes that you fly in from Kathmandu to Lukla have to land on that runway, and it's a very short runway, and if they miss it, you crash into the side of the mountains. And every year there's a few deaths on this at this small airport. And you know, it's not just the airport, it's the bus drives and everything else. Like, it's pretty hazardous. The risk is just such a bigger part of everyday life in a developing country, that you can't have all the worries that you would normally have, like in Canada, about safety. You just have to let it go, because if it happens, it happens, but you're really going to have a horrible time if you're worried about what might happen all the time, because life's a lot more risky in developing countries. And this village is actually, you know, very well off relative to many other villages. It has a hospital that was built by a Swiss NGO, but when we walked by that hospital, there was a big fence with a gate that was padlocked, and there was no activity in the hospital because there were no physicians or nurses or any kind of medical personnel to operate that hospital. And then over about a 3-week period, we walked through the Hinku Valley, and there weren't really any permanent villages in that valley. It was mostly like tea houses that were seasonal as trekkers came through. We had with us, we were going to climb quite a large peak, Mira Peak, that's about 6,400 meters, and we had with us about 20 porters. And one of our Sherpas, Pasang Achi, started having chest pain while we were trekking, and he had forgotten his medications apparently, so he had to leave us to go back to his own village to pick up the medications. But for him, going back to his village meant walking, you know, at high altitude along this trail. And that's just the way life is there. It's very, very harsh, and and when you know, if you die, you die. There's just like no big fuss made about it. Most of the porters that come from actually the Terai, they're not acclimatized to high altitude, but the pay is relatively so good if they work for a trekking company that these are highly sought after jobs, even though they're physically extremely demanding. So on the left-hand side, you can see a porter carrying a heavy load. They carry weights of up to 60 kilograms, and Nepal is well known for the way they carry these loads from a young age. They learn to carry them basically on a strap around their foreheads, and it has to be perfectly aligned with your spine so that you're able to balance this load. And when I tried to carry a load, like I could only go a few steps with it, which was really kind of humbling, because these people are walking along with flip-flops, carrying these loads for many kilometers, and I thought I was in pretty good shape, but I had a lot of trouble carrying that load. So there's great financial incentive to work as a porter, even though it's an extremely hard and hazardous job. And along the way, we went by many little tea houses, and really I couldn't stay in a tea house for very long, and this goes to one of the main problems that result from the fires that they have in these small homes. The fires and just all the smog, even in this like mountain environment, result in chronic obstructive lung disease that's very prevalent in Nepal and other developing countries. So you don't see it too well, but these little hovels, they're usually just built of stones, and they have tin or aluminum roofs, or sometimes, you know, depending on the altitude, lower down, they'll just have wooden roofs. And often they'll block off, if there's a chimney, they'll block it off because they want to preserve the heat from the fires. So that creates a very smoky interior. And like, the oxygen level is already low at this altitude, and with the smoke, like I became quite short of breath after being in one of these little tea houses for more than 10 minutes. And there's lack of sanitation. So like defecation, they do have little outhouses in some of the villages, but I don't know how many of you have seen Slumdog Millionaire, but at the beginning where he's kind of in a little outhouse and he's worried that he's going to fall through, that's exactly what the outhouses were like along these trekking trails. So, you know, the boards were kind of rotten, and you didn't really want to go in there because you were afraid you'd fall in and not be able to come out again. So like people would just defecate out in the fields. And of course that's horrible for the drinking water. You have to boil or treat all water from the mountain streams because it's contaminated by human waste as well as by animals, the water buffalo that they have up there. So no sanitation, no clean water, and a lot of smog in these houses. And yet, you know, the people were amazingly friendly considering their difficult lifestyle. And this was one of our Sherpas, Angche, and he would always smile. Like whenever he was doing anything for us, whether it was bringing us tea or supper, he would always present it as a gift with a smile. And it was just really so heartwarming. And smiling and a sense of community were pretty much all these people had in terms of what they were able, you know, how they were able to feel better about their lifestyle. Another person told me, an obstetrician who works in Nepal, she told me, like, music and dancing are so important for our people because that's about the only thing that brings them joy sometimes and allows them to escape their harsh circumstances. So our climb was Mira Peak at 6,400 meters, and it was not a difficult climb, but at that altitude, you just get short of breath very quickly. So it was a beautiful climb, and we could see Everest off in the distance above the clouds as we were getting higher up on Mira. And I just remember thinking how glad I was that I actually wasn't on Everest, that Mira was hard enough. And on our way back through the Hinku Valley, people get sick routinely. Trekkers, foreigners get sick often because of infections or acute mountain sickness, or pulmonary edema, cerebral edema. And in general, trekkers who get sick are evacuated very quickly because they have insurance and a helicopter will come in and whisk them out of the valley as long as the weather is good enough for the helicopter, because the helicopter can't usually fly through really dense clouds and no visibility. So no problems evacuating trekkers, but there was a porter who died on our way out, and he died from pulmonary edema that wasn't recognized by the other porters. He just felt really short of breath and wanted to be left alone, so they left him alone, and in the morning he had died. So they transported his body out to Lukla. So just different awareness, different reality for porters as opposed to foreigners. And yeah, you know, I really liked the people that I met. There was not much technology there in the Himalayan villages, but the people seemed to enjoy simple things like, you know, playing the flute, playing little games with each other, just kind of running around and being together. The two on the center photograph at the top, those are two Sherpas, and both of them have been on Everest multiple times. You know, when you hear about Westerners going up Everest, it always looks like a big deal. But like these guys have been up more than 10 times. For them, it's just a job, even though it's a very hazardous job, guiding on Everest. So then, after that trek, which gave me some idea of what life might be like in the Himalayas, very, very impoverished areas, the next two times I was in Kathmandu, which is the capital of Nepal. And it's a big city, very disorganized city. And there's just lots of garbage. The first time I went to Kathmandu, I was just struck by all, you know, the unfinished houses, garbage everywhere, just chaotic streets, motorcycles. There's a lot of noise and smog. And then, of course, once you live there, you realize that, you know, if you're in a hotel, it's not bad, but when you actually live in the city, there's power outages every day because they don't have enough hydroelectric power, especially in the winter time when there's less runoff from the glaciers in the mountains. So power outages in the winter can be 16, 18 hours, no electricity. And different neighborhoods or different areas will have no power. And the water from the water taps in Kathmandu, well, it's kind of brown and you certainly don't want to drink it. So people usually will drink bottled water that comes from wells. And the cities, well, the streets are crowded with all kinds of people, like people carrying heavy loads, a lot of motorcycles, and the traffic is just going in every direction. So you have to be very careful crossing any intersection. And then there's dogs and cows wandering through as well. So it's very different. So Dr. Solez has been involved with this medical school since its inception, or since they thought of putting it together. But my involvement started in 2010 when I went to the first meeting there, and then I went for 5 weeks in July 2011 and September 2012 to teach in the cardiovascular block, so very related to what I do here. And this hospital, the medical school is attached to the Patan Hospital, which is a neighboring city to Kathmandu, like it's just directly adjacent to Kathmandu. It's a very ancient city with lots of temples. And we gave lectures there and did some clinical skills teaching, and then problem-based learning is very popular in medicine, and we had that at the Patan Academy of Health Sciences as well, and that's a photograph of the group that I had this past fall. And you know, the students are very different from here. They're very young, first of all, in medical school, so they're directly from high school. They don't have an undergraduate degree. They're very polite. They always call you ma'am, you know, ask permission to enter the room. They memorize really, really well. So they remember like sections from a physiology textbook. But then when you actually probe for understanding and being able to apply that, it's more difficult. So, but they're so enthusiastic. Like they just always want to get up and explain things. Even when it's wrong, they're just like, they want to talk to their friends, and they're very appreciative of having a foreigner as well, which I found was rather disconcerting. Like, because they have their own excellent clinicians, but they just value having someone who comes from North America or Europe. And I guess you can't see too well, but in addition to myself in the cardiovascular block, there was Carol Ann Cornea with the orange t-shirt, who's a cardiovascular physiologist from UBC, and Jason Wechter at the end, who is an intensive care specialist and anesthetist from Calgary. So we were there to teach in the cardiovascular block, and there were some students, medical students from UBC, who were with us as well. So it's great exposure for medical students as well, of course. Life in Patan, well, we lived in that house that you see on the left-hand side, and that was really a very nice house by Kathmandu standards. Of course, we had 2 rooms at the bottom. And, you know, life is really lived out on the streets. People would be brushing their teeth in the morning and spitting in the streets. And there'd be little parades coming by, like this was a wedding ceremony that just came by the backyard and back alley. And we got our water in these big bottles, and it came from wells. And even the well water wasn't entirely safe, so we would always boil it or add chlorinated drops. And it's inevitable, like Westerners who go to Nepal inevitably become sick at some point, so we had a supply of antibiotics to take as soon as we developed any gastroenteritis. No matter how careful you are, it's just a question of when you get sick. So at the Patan, so in addition, the medical school is like right beside the hospital, and we also worked in the hospital. So the Patan Hospital has 450 beds. And, you know, it's very different from the hospitals that we have here. The family is always around looking after the patients. There aren't that many nurses around. And patients have to pay for everything if they can. If not, there are donations, charitable donations that the hospital gets from international aid, and also a small amount from the government. This hospital was established in 1953 by a religious organization, United Missions to Nepal, during a cholera epidemic, and cholera is still common in Nepal. Like any developing country, it has a large obstetrics, pediatrics, and orthopedics department because of all the trauma. Hospital revenue comes mainly from patients and donations, and the staff become very good at assessing the ability of the patient and their family to pay. There's new services in the hospital, and they keep growing, but the problem with echocardiography anyways, which is like the area that I'm involved with, cardiac ultrasound, technology breaks down. And when it's broken, there's no one around to fix it. So it'll just sit in a corner for a long time until someone else donates a piece of equipment. That's a real problem. They do have ventilators, but they're very simple ventilators in their intensive care unit. They've started hemodialysis, and they have a physician who's going to be coming here to Edmonton to train in nephrology, and she'll run the hemodialysis unit. So, you know, things happen, but in a very unpredictable fashion, depending on who happens to come by, who happens to make a donation. It's very different. And when equipment breaks down, there's just no replacement. You just have to do without it. So I was involved with doing echocardiograms while I was there. And you know, anything you do, you want it to be sustainable when you leave. So on my first visit, I trained one of the internists there to do echocardiography. But the problem was soon after I left, the machine, the transducer broke down, and they weren't able to get another one. So basically no one could use the echocardiogram machine for adults. The pediatric transducer was still working. So on my second visit there, I really couldn't do very much in terms of echocardiography. That's just the way life is there. Sometimes things work and often they don't. And then if the patient has money, then they would go to like the heart center in Kathmandu to have an echocardiogram done. And if they can't afford it, they don't get the test. And just what I would see with echocardiography, I did see there's a lot of lung disease in Kathmandu, so a lot of right heart failure related to chronic obstructive lung disease, and that's from the pollution. Like I always thought Nepal would be, you know, pristine and wilderness area, but it's not. It takes a very developed country to be able to handle technology that we have in garbage that's produced. So, you know, people just burn their garbage in the streets, and then there's brick factories that emit a lot of exhaust, and there's diesel trucks, so the air is very polluted in Nepal, in Kathmandu. So just to contrast the patients that I'm used to seeing here compared to the patients that I saw in Kathmandu, this is one of my patients who died about 2 years ago. So he was 66 years old, and he had coronary artery disease, which is the most common heart condition that we see. And the risk factors for that, he had them: type 2 diabetes, hypertension, obesity, high cholesterol levels, former smoker. He had a large heart attack when he was 52 years old, and he had good treatment for that, but he did still sustain a lot of heart damage, so he developed heart failure after that. And you can see all the medications that he was taking. And these medications improve symptoms and prolong life in people with heart failure. But, you know, it's costly, it takes supervision, and in a developing country, people don't generally take medications unless they have an acute problem, like they have a fever. Then they'll go see the doctor and take antibiotics. But they're not used to taking medications for chronic disease like high blood pressure. And you can see how this man has quite a complicated medical regimen, including insulin. And then he gets a lot of technology. You know, he gets a defibrillator implanted to prevent sudden death. And then finally he gets worse and worse. And finally he's assessed for a heart transplant, but not a good candidate because he has too high pressure in his lungs. So he gets a very sophisticated, like an artificial heart implanted, a left ventricular assist device. But he dies a few days afterwards because of end-stage multi-organ failure. And despite the LVAD, he died. So this kind of treatment is high-tech, it's chronic, it's ongoing, a lot of different problems that require highly specialized care, and it's very costly. Well, this was a patient that I met when I visited the heart center in Nepal. Very different and like very, very sad. An 18-year-old man who was admitted to the heart center, and he's a charity case, so that means his family has no money for any health care. And he had recurrent admissions to the heart center because of heart failure at 18. And when I saw him, like, he was very thin and a lot of muscle wasting, and he was a little short of breath even at rest. And his problem was his mitral valve had been destroyed from rheumatic fever, from repeated episodes of rheumatic fever. Now, rheumatic fever is very rare in Canada, but in developing countries like this, it's still common. And rheumatic fever occurs from a bacterial infection, from a streptococcal infection. And when people live in very close proximity, like in crowded conditions, infections are transmitted all the time. So streptococcal infections are very prevalent, and then your body mounts an immune response to your heart, because there's some antigens in the heart that resemble that of the streptococcal bacteria. So he had had several episodes of rheumatic fever to the point that his mitral valve was destroyed and his heart function had decreased by the time he was 18 years old. So I have never seen this in Canada. And at this point, like, the disease had progressed so far that his heart function had deteriorated. Even if he had a valve replacement, he would still have been left with heart failure. And valve replacement was was not an option anyways, because it was too expensive. So he was going to die in the next year or two because of heart failure from rheumatic fever, which is a totally preventable condition. So, you know, his heart disease is a result of poverty and social inequity. So the different phases of, I mean, I can talk about heart disease because that's like the area I'm most familiar with, but I'm sure it's applicable to other medical conditions in Nepal. So the Nepali patient with heart disease is young compared to our patients here in Canada who are much older. The problem, the cause of the heart disease is an infection in Nepal, and here it's more degenerative, aging and vascular lifestyle factors and genetics. Cost of care is really cheap in terms of preventing rheumatic fever. Rheumatic fever is mainly prevented if people have better social conditions, so better homes, you know, more space, more prompt treatment of infections, so you can prevent it. And once you have rheumatic fever, if you get a penicillin injection every 3 weeks, then that prevents recurrent episodes of rheumatic fever and destruction of heart valves. So really it's the cost of penicillin, which is pretty cheap. Whereas the management of our patients with coronary artery disease is very expensive. There's a lot of medications to take every day, and then there's sophisticated devices. So Nepal, you know, there's urban, Kathmandu and some other cities, and then where most of the people live, in rural Nepal, very different. In Kathmandu, there's increasing rates of ischemic heart disease, coronary artery disease. And in the rural Nepal, infections still predominate. So the WHO data on Nepal are that 50% of deaths are related to infections or maternal perinatal deaths, so related to pregnancy and during infancy, and malnutrition. Diarrheal diseases are rampant, and we all get them. And you know, you'd think that the locals wouldn't be as susceptible to gastroenteritis, but they get just as sick. I mean, they're routinely sick. And acute respiratory diseases are also common because of the pollution. Vector-borne diseases are like malaria is very common. TB is endemic. And in addition to these diseases that were very common in the early 1900s, Nepal is, in the cities especially, is also seeing increasing vascular risk factors and chronic non-communicable diseases like heart disease and coronary artery disease and cancer. So atherosclerotic coronary artery disease is becoming more prevalent in Nepal because of aging of the population. So, as maternal health improves and children aren't dying in childhood and adolescence, and the population gets older, heart disease does become more common because it is a degenerative disease. You generally have to be over the age of 50. Urbanization, decreased exercise, fatty and salty diet contributing to high blood pressure and high cholesterol, smoking, air pollution, and there's a genetic predisposition among South Asians as well to have severe coronary disease. So a country like Nepal obviously would have trouble dealing with an epidemic of coronary artery disease, chronic non-communicable diseases. And really the most important thing is to have a good infrastructure in society to prevent disease as much as possible. And that relates back to Virchow's thoughts on this subject. Nepal has huge challenges to get to a healthy population. So unstable government and rampant corruption. I mean, the hospitals really don't have a budget that they can rely on. It's very hard to deliver good health services when you have a corrupt government. There's lack of reliable infrastructure, so the roads are in very bad condition, sometimes impassable. Electricity is sporadic. Poor sanitation, lack of safe drinking water, that results in a lot of diseases. Poor nutrition, pollution, then where the geographic location, vulnerability to disasters, there's often landslides in the mountains, and the Kathmandu Valley is in a major earthquake zone. Social and health inequity, I think a lot of that comes from the unstable government and corruption. But it's very hard to deliver good health services when you don't have good sanitation and clean air and water. There is some advanced medical care available in Kathmandu for people who can afford it in general. So in Kathmandu they have a National Heart Center, and we visited there. And they have a very good group of cardiologists. I did find the doctors that I met were very skilled. They had very good clinical skills because they didn't really have a lot of technology that they could rely on. So very good bedside skills. So in this hospital, this major heart center in Nepal, it's the major one, when you look at the surgeries they do mainly valve replacements, as opposed to us here in North America. By far our major surgery is coronary artery bypass surgery and dealing with consequences of myocardial infarction. Well, in Nepal, because they still have so much rheumatic fever, they still need to do a lot of valve surgery, and they have a lot of congenital heart disease. And they only operate on patients who are likely to do very well after surgery. So surgery will fix the problem. As opposed to here, like we operate on people who have a lot of other problems, and they may or may not do well after surgery. So they only go for simple operations that will make a big difference. And in the corner of the ECG lab, there was a little cubicle for penicillin injections. There's so many people who need to come in every 3 weeks to have a penicillin injection to prevent rheumatic fever and destruction of heart valves. They had some nice echocardiographic equipment and a cardiac catheterization laboratory, but it was actually a pretty quiet place, this hospital, and I think it's because most people just can't access this higher level of care. So when we met with the cardiologist at the Heart Center and we asked them, well, what do you perceive as the greatest needs in terms of cardiac care in Nepal? they felt that their biggest problem was still advanced rheumatic heart disease, which is pretty much eliminated in North America. But they did note that there was an increasing number of young patients with coronary artery disease as well, like in their 40s. So that's very worrisome. And this isn't just Nepal, this is throughout developing countries. In addition to the communicable diseases that have been the major causes of death, now we have increasing rates of non-communicable diseases as well, so cancer and chronic obstructive lung disease and coronary artery disease because of this hostile cardiovascular environment, as well as probably some genetic vulnerability. And this is coming on countries that have very limited resources for health. So very concerning now that most heart attacks in the world are occurring in developing countries now, not in developed countries. So what about healthcare in this type of environment? Well, the major problem is that physicians, there are a lot of medical schools in Nepal, about the same as in Canada in terms of the number of medical schools for a similar size population. But the problem is that the physicians who graduate, the schools are mainly private, so you need a lot of money to go to these schools. And then most of the physicians who graduate will either leave the country to practice elsewhere, or they'll stay in Kathmandu, in the major city. So most of Nepal, rural Nepal, has very few physicians. You see, in the mountains, it's one physician for more than 100,000 people. So there was a person who wanted to make a difference, wanted to increase the number of physicians who would work in rural Nepal. And this is Dr. Arjun Karki. So he was the one who, with his friends, both physicians in Kathmandu, and with an international faculty that included Dr. Solez from very early on, made plans for a medical school that would be specifically focused on training physicians for rural Nepal. And this is a photograph from the last meeting with the International Advisory Board, and they met. He was very well connected with the government, and some members of the International Advisory Board met with the Prime Minister of the country during the last visit. So he's on very good terms with very influential people. That's pretty much what it takes. And this medical school opened in 2010 with the first group of students. And you know, to me, it looks a lot more like a high school would than a medical school. It's attached to a hospital, so that's good. But you see the classroom over on the left-hand side and one of the PBL rooms, the small group discussion rooms on the lower left-hand panel. And then they have some books in the library, and mainly donated from international faculty. And they have about 30 computers, and the class size is 55 to 60. So students enter directly from high school, and first class, the first cohort had 18 women, 42 men, and they always try to get people from rural Nepal, because those are the people who are most likely to go back and practice in rural environments. They have scholarships, both international and private scholarships and government scholarships available for students. The full tuition for the 6 years is $50,000, so it is expensive. It's a 6-year program. And what do they do to try to get physicians who will work in rural Nepal? Well, first of all, they try to get medical students who come from remote villages. So when they go to do interviews, they'll do them in 2 sites, one in Western Nepal, one in Eastern Nepal, to try to get local students, make it easy for local students to apply. Because locals don't travel very much. It's too hard to travel. They give scholarships to students from rural areas. And they have rotations in rural communities from the first year of medical school. So they make the students go out into the slums of Kathmandu or into the villages and live with families there and see what their needs are. The students who are on scholarship have to go back and service a rural area when they graduate for variable lengths of time. And then they can come back and they have priority for postgraduate residency positions. And the plan is to improve their infrastructure so that they have better telemedicine support for positions in rural areas. So, you know, what I observed with technology is it's very hard to have a lot of high tech when you don't even have power on a reliable basis. So it's just, the stage things are at now, it's just really important to have curative, affordable, accessible therapies, kind of low, what I would call low maintenance therapies, like mitral balloon valvuloplasty. So, you know, a procedure to open up the mitral valve. If it can't open properly because it's been affected from rheumatic fever, that's a wonderful procedure. Reusing catheters and pacemakers, that's also a good procedure because it doesn't require a lot of maintenance, long-term care. But the simpler, the better in general. Cell phones have made a huge difference in developing countries. And 70%, it's one of those leapfrog technologies. Like when landlines were required, phones were not accessible in developing countries, but cell phones are vital to, they're more important than food for many people who are trying to make a living in Kathmandu. And this is taken from a monastery in Kathmandu, and the monks are on their cell phones too. 70% of the world's 5 billion cell phone subscribers are in the developing countries. And 90% of the world's population has access to a wireless phone signal. So that's pretty amazing. In India, even in villages, 33% of people have cell phones. So cell phones are very, very powerful and can be used as a way of improving access to health resources. So, you know, technology obviously has made our life here a lot better. And there's tremendous benefits from technology. I think in a country like Nepal, it has to start at a basic level, like assuring clean water and sewage management, pollution control, better infrastructure. And then in terms of health, you know, vaccinations are really important, better nutrition, better farming techniques and crop management. All those things are really important to improve the health of a developing country. There are some disadvantages. You know, there's things that people in Nepal don't have, but there are things that they do have that we are kind of losing here, and I was really, really struck by that. In our more technologically advanced society, we do have kind of a decreased sense of physical community, I would say sometimes, because we're not, even when we're together, people are often on their smartphones and, you know, thinking about other things. Over-reliance on technology, you need to have systems in place to repair things when they break down. And sometimes technology results in a loss of appreciation of the present moment and the simple things that really enhance one's life. And in Nepal, like, you know, when you go into a store to buy something, the first thing they ask you is whether you want some tea. So, you know, it's kind of nice. I read this editorial by Thomas Friedman from the New York Times, and I was quite impressed by this. He writes about the virtual middle class. So India, with its population of 1 billion, has about 300 million people who are in the real middle class, and it has another 300 million that he says are in this virtual middle class because of the diffusion of education and knowledge through cell phones and the internet. So massive diffusion of cell phones has resulted in a virtual middle class. So these are people who are actually poor, like they don't have clean water, and they live in slums in very crowded conditions, but they have their cell phones and their internet access. And that has raised their expectations. You know, they don't want a corrupt police force anymore. They want clean water, and they're making demands on their government for that. So that's made a huge difference. And there's entrepreneurs in India that have developed these kind of simple things to improve life, and most of them get American aid as well. So Gram Power, this company called Gram Power, uses smart microgrids, so it gives people a card that they can use that will provide them with enough electricity to power home appliances for 20 cents a day, so really cheap at times when the electrical grid is not overloaded. Health Point Services provide safe drinking water for 5 cents a day. Then there's, glasses, and there's an Institute for Reproductive Health that texts women when to avoid unprotected sex so that they don't become pregnant. So small things, small scale, but certainly showing the possibility that technology can improve life, and on a small scale, but also on a larger scale as social unrest results hopefully in some changes to government. Now, the concern is, as technology advances, will there be more division between have-nots and those who have a lot? And I think it's kind of inevitable. I don't really see that social inequity will disappear completely, but I'm still hopeful that life will improve for many people in developing countries, and that it won't just be a testing ground for new technology, but with some aid from foreign countries, from more developed countries, that there can be improvements, long-standing improvements to the infrastructure. But I think it has to come from the people themselves. I don't think you can just parachute in solutions that other countries have found. I really think the people have to want a better life and have to know about it. And I think technology has made a huge difference in terms of raising awareness of how much better life could be, how much safer it could be. And why should we help as much as we can? Well, I think we learn a lot when we go to these countries, and kind of we help ourselves. But when we help other people, it really comes back to us. It's for our own good, because as people travel, there's transmission of infections like the cholera from Nepal that was transmitted through healthcare workers in Haiti during their recent problems. Terrorism, as social gap widens, that spreads to other countries. So it's important to help people in developing countries. And altruism, well, it's easy to ignore things when you just read about them in the newspaper, but when you're actually there, it's a little harder. So I'll let you read this by Albert Schweitzer. So I think that applies, obviously, not just to developing countries, but everywhere. And lessons I learned from Nepal, well, first of all, was technology is great, but it's simplicity, community, and physical togetherness are also really important. And I really was interested in this book by Sherry Turkle, Alone Together, Why We Expect More from Technology and Less from Each Other. And she's a psychologist and sociologist from MIT who writes about the problems with technology. How just, smartphones make it very easy to engage at will and disengage. So you're kind of avoiding all the messiness of emotional togetherness. Can't read things too well here in these notes. So there's an illusion of companionship that you get from technology, but it's not the same as actually physical closeness. And then, from Arjun Karki, he's just someone who dreamt big. Like, he had a vision how life could be better in rural Nepal. He had so many hurdles along the way in developing this medical school, and they're still ongoing, but he just gathered together a group of like-minded people, and he just kept working at making this medical school become a reality. So I think it's important to dream big and being open to new adventures and taking risk. I think that was, going to Nepal was a big adventure for me, and it was a bigger adventure living in Kathmandu than trekking in the Himalayas. And just made me realize, like so often we see things from our own cultural perspective, and we don't realize how very different it is for other people. And I'll never forget this conversation I had with one of the young doctors at the Patan Hospital. He was telling me about how he was working in rural Nepal, going from village to village in the Himalayas, and they were doing these health camps sponsored by a foreign NGO. And this was the winter time, and I said, oh, it must have been beautiful in the mountains. And he said, well, I was cold, hungry, and tired. And I didn't quite understand that. So I said, well, but I mean, you're in the high Himalayas, and it must have been gorgeous. And then he said, you know, they have a very impassive face on us. He said, I was cold, hungry, and tired for 3 months. And then I got it. And I understood that, you know, when I go to the mountains, it's for a short period of time, and I have all this wonderful clothing that from mountain equipment co-op and Patagonia. And, you know, we're warm, we're well fed, and we walk around and admire the beauty of the mountains. But living in the mountains, it's a totally different story. They go without food for days on end because they just haven't had enough crop to last the winter. So it just made me realize that it's just important to try to understand things from other people's perspectives. And then I think I don't really think that we made a big difference to people's lives there, but certainly I felt really happy because other people just seemed to appreciate our presence there so much. So you certainly get a good feeling. And then when I came back to Edmonton, I realized, well, in Canada, there's many disadvantaged people that you can work with as well. You don't really need to travel to a developing country to do any of this. Big adventures and different cultural perspectives. I mean, I think we have it all right here in Canada, and we can do a lot of good here as well. So finally, I want to thank you for your attention.
So, questions? Yeah.
Thank you for the great talk. I have a question regarding to the politics changes which is going recently in Nepal. Their young mice just said that at the end of March they are going underground again. Yesterday their prime minister is changed. I want to ask, with all these changes, going back to the civil war and changes in the politic aspects, where do you think all these advancements and all these plans will go?
With the
Will
change
it work?
in government. That's been an ongoing problem in Nepal after the monarchy was overthrown. It's a very, very unstable political situation. The civil war affected rural Nepal a lot more than Kathmandu. But like when we were in Nepal, there would be days when there would be a general strike, like a banda, and so that meant there was no vehicles were allowed on the streets, and all businesses were shut down. And then even at this medical school, the government appointed a vice chancellor who had basically bribed the government officials to get that appointment. And then the faculty at the medical school and the staff went on strike, and so finally they were able to get that vice chancellor removed. But it was a long process. So I think that gradually things are improving, and it will come because people demand that. You know, they just will not, they won't tolerate that corruption.
Thank you. Another question that I have, I know in Nepal all kind of medicine is available for everybody. They can go and take it from pharmacy and they can cure themselves based on what they think or their parents or old people they say. What do you think it has impact on they just postponing going to the doctors and realizing that, okay, it is heart problem and not just simple fever?
Yeah, I noticed that. So like in Kathmandu, there's pharmacies and you go in and you can, without a prescription, you can just buy, for a few pennies usually, you can just buy any antibiotic. So there's huge problems with that. So sometimes that it's not actually the active drug or it's mixed with other substances. So you don't always know what dose you're getting and actually whether it's the drug they say it is. And then the other thing that I've noticed was there's a lot of antibiotic resistance. So it's a huge problem when people can just take an antibiotic, can access it very easily and take it for a fever that may be viral. So I don't think that's a good solution at all. I think there should be like better access to health professionals. Nepal is well known for its female community volunteers, though, like women in villages who assess villagers and give them antibiotics if they think it's likely a bacterial infection. So I think it shouldn't be antibiotics, you know, that you can get so easily, because that just leads to very serious infections with antibiotic-resistant bacteria. And we actually have cases of that coming back to Canada as well, like people who've been to India and get an infection there that's highly resistant. And then they come back to Edmonton and that infection can spread to other people. That's happened here. So very bad to have easy access to antibiotics or any medical.
Hi, Dr. Cujec. Thank you very much for a very enlightening talk. I was just curious as to whether you thought that obviously ultrasound was introduced because it's quite an affordable technique to use. I mean, I'm under the impression they probably don't have MRI or CT. Is that correct?
They don't have MRI or CT in this hospital, but patients can be transported to other hospitals for CT. I don't think they have MRI.
Okay. So do you see that the bridge or the gap between diagnostic medicine in Nepal? Do you see that being repaired as the costs of technology decrease and the types of technology and the developed technology improves? So now they're starting to test handheld ultrasound scanners, and I think they cost like 15 grand or something like that. And they're showing some pretty good results. So if these are transported over to Nepal, do you see that being sort of like the cell phones having the same sort of effect as the cell phones? All of a sudden, diagnostics is more available. People are more likely to go seek healthcare because they see it as being more effective. Do you think it could have that sort of run-on effect?
So that certainly happened with computers and with cell phones, a lot less expensive as the technology has become more miniaturized. And we actually looked at getting a V-scan, which is like a handheld ultrasound for this hospital, and that's only like $7,000. It's not a lot. But I looked at the image quality, and it really wasn't good enough for a large community hospital like this. So I didn't think that was a good option for them. It just wasn't, it was small, and it was inexpensive, but it wasn't good quality enough. And it didn't have Doppler, because they see a lot of valvular disease. So it wasn't there yet.
No, I can see that being a problem. There's actually a recent publication that came out at the end of last year that compared the GE handheld scanner against you know, it must have been like a Vivid 7 or something like that, a high-end scanner.
Yeah.
And they showed that in 256 cases or something like that, they only missed 9 mild mitral regurgitations, and all other disease was picked up relative to the high-end scanner. So I presume that is something that will keep developing in the future.
I think so, and that's obviously really important, like cheaper technology, simple technology.
Yeah.
Yeah.
Okay, thank you.
Thank you for the talk. Yeah, I'm just, I think Nepal exactly is not a good example for developing countries. I went to many developing countries before. I think Nepal is like an example of a country having a certain lifestyle different from many other countries, like the mountain, they have mountains. I can't imagine they have a very small airport, just a runway, very small. They can't fix the sonar, they don't have engineers. I think like Nepal, for my opinion, is not a good example for developing countries. Developing countries have everything the same maybe as Canada or USA, but with low. They have lower universities, they have lower hospitals, they have lower healthcare. So for my opinions, like Nepal is not a developing country, it's a country that's having a harsh lifestyle, different from other countries. That's my opinion, yeah. So.
Well, you know, the WHO has these low-income developing countries, and I mean, they classify Nepal as a developing country. You know, I think it's based on the literacy rates, the life expectancy at birth, infant mortality. I mean, they're among the worst of all countries in the world. Like, they're definitely in the bottom quintile. There is sub-Saharan Africa that is definitely probably worse off than Nepal, and that's because of a lot of wars as well and famines. Yeah, you know, Nepal. I can't say I saw a lot of malnutrition on the streets. Like, people are thin in general. But they are neatly dressed, and, you know, I think it's certainly, you know, when you look at the numbers, though, like the population determinants of health, they're very poor.
You mentioned a phenomenon known as the virtual middle class. I was just wondering what your opinion on that was, as maybe something that will in the future level the playing field and bring that class gap closer together, because as information becomes easier to access, people begin to get smarter, conditions improve. Yeah. So do you think that countries like this will eventually be able to catch up to Western culture?
I sure hope so. I mean, I think this is the most positive, like, the internet has had a tremendous influence on information diffusion. And I think once you know how life could be, it's kind of like that quote from Virchow, if you're just used to a certain level of difficult lifestyle, you just accept that unless you understand how much better it could be, and how you don't need to have so many children dying so young. And yeah, so I think it will make things a lot better. It's slow coming, though, because, you know, when you look at the social unrest in Egypt, I mean, it takes a while.
I was just wondering what you think should be a priority for developing countries like Nepal. You spoke mostly about like healthcare, but that could be, you know, because of your background and the nature of this course. But I was wondering what your take is on other things like education and infrastructure and halting corruption. Which do you think should be a priority so that they can develop, basically? Yeah,
absolutely. I couldn't agree more. Like, to me, I think of healthcare as kind of the icing on the cake, and the real cake is the infrastructure they have. Education is huge. It's so important to, I mean, I think that's, when you give aid to a country, you want it to be sustainable, and I think education is probably the most sustainable, so that their own people can be empowered to make the changes that need to be made in their society. So I agree, like there's no sense in replacing heart valves if the person's going to go out and not be able to have their blood monitored so they're on the right amount of anticoagulant, and if they're still in an environment where infections are rampant, because then the valve will get infected. So what's made the biggest difference in improving health in Canada, for example, was, I guess, in the 1930s, before the advent of antibiotics, when social conditions improved. Yeah.
We're out of time. I want to thank you very much for a really excellent session. I wanted to recommend to everybody Abdullah Salah, who speaks on global citizenship. There just isn't time for him to teach in this course this year, but the video from last term is really perfect. He says it's because the call schedule was the way it was, and for the first time he was rested. So he actually felt good when he was, and really everything is so precisely explained, and it fits very well with this talk today. So I can't force you, but for those of you who would like to, you can go to YouTube, and I think you'll see what I mean, that this talk and his fit very, very well. Thank you all very much, and see you next Tuesday.